Good afternoon. First of all, thank you to the President, Dr. Amit Gupta, Dr. Parul, for accommodating me. I have to go for another session. So thank you and very kind of you. And thank you to my seniors, Professor Dogra, Professor Panda. Thank you. And so I won't take much time. This is, what is the timer? The timer is?
7 minutes.
Okay. Oh, I have already exceeded. Okay, fine. So basically, I won't take much time. Yeah. So basically, what we are something new is that obviously the newer imaging modalities basically are helping us to plan our surgeries better. So we have now the surgical techniques which have improvised, and we are shifting from a cosmetic improvement to a functional improvement, which means fostering binocular vision and stereopsis. So basically, this is just one of the papers that was published using the anterior segment OCT for locating the extraocular muscles when planning for a resurgery. So that's what we can do. We can find the distance of these muscles from the limbus, and you can see here some kind of a stretch scar as well. So in this patient, probably who had an overcorrection, we could find what the cause was, and that is what we had intraoperatively, the stretch scar which was removed and the muscle was sutured back. So that's how imaging really helped us in this case scenarios. So coming to some of the surgical procedures, well, you have something like the heavy eye syndrome. A lot of procedures have been done. So this eye, the patient is highly myopic, eye doesn't move out. You had different procedures for doing all these things. But the newer procedures that has come up is basically what we do is the zip loop myopexy. Here what happens is the superior rectus and the lateral rectus, basically the superior rectus is shifted nasally and the lateral rectus is shifted inferiorly. So you have to basically bind those two with either using some kind of a non-absorbable suture or basically doing a zip loop. That means zipping the lateral rectus and the superior rectus so that the globe is pushed centrally. So that's how basically what is done. This is just to show you the animated picture of what basically when you do the two muscles. It was initially done, just put a band here or just suture it, but what you're doing is zipping both the muscles so that a broader area is covered. So you can see here what happens. We just done one eye. If you see the left eye, what is done, it's not moving out if you see here, but when you do that zip loop myopexy, the eye is abducting as well. It's come to the center as well. We'll do the right eye in the same way. So that's what something better which is happening now. We're using the newer techniques which are coming up. So coming to thyroid orbitopathy, again there is sometimes there is inferior rectus restriction here because of fibrosis. So what happens here, the eye is not really moving up. So even after doing a large recession, that means loosening the inferior rectus, what happens is it's still into the hypotropic position. And they say that in thyroid ophthalmopathy, never resect because it leads to loss of fibrosis and inflammation. So what we did for the first time, probably it's never described, is we did a plication. That is folding the muscle on itself and tightening rather than just cutting it, and we could get a good central position in this patient. So that's what we did here in this patient. Coming to Brown syndrome, another restrictive condition. What is Brown? Basically, the eye basically doesn't go up because of some superior oblique problem. If you see here, the patient is looking up, but this eye is not going up. That's because the superior oblique is tight. So what happens here is you do a split lengthening. That means in the superior oblique muscle, what you do is lengthen the muscle by about 10 millimeters. So you split half here, the superior oblique, and split half here. So it lengthens here. So that's what we did in this patient. And that's how, if you see the post-op position here, this eye is not going up, it's down. What happens here? The eye is centered and the eye started to go up. So this lengthening procedures are something which have come up recently, and it's really something, you're not putting a foreign body. Earlier they used to put a silicone band inside, so it's no foreign body implantation inside the muscle, and you can just lengthen the muscle and improve the condition. So transposition procedures, something new which has come up. Again, we had described option for, because in third nerve palsy, we just have one, what is lateral rectus, that is functioning because that's supplied by the sixth nerve. So with just one muscle, what you can do is you can transpose the lateral rectus medially. So what we did here was basically split this lateral rectus into superior and inferior halves and take it to the medial side. So if you see this patient with a third nerve palsy, because the lateral rectus, only the lateral rectus is functioning, the eye is out. So we could get it into the center here by just one muscle surgery. So the other thing which has come up is superior rectus transposition now. This happens again in restrictive syndromes or in sixth nerve palsy. If you see, the eye doesn't really go out. If you see the left eye. So instead, people could do, earlier we could do basically a recession of the stronger, that is the medial rectus, or you could do a resection of the lateral rectus, but because there is no force in the lateral rectus, and if the deviation is large, probably a superior rectus transposition to the lateral side here would help in the abduction as well If you see here, there is some amount of abduction. Obviously, you cannot get a full range of movement here. The eye is centered here as compared to this, and there is some abduction here. So with just a medial rectus and a superior rectus transposition, we are able to get a good result in these cases. So that's what basically the transposition procedure was. Now, if you don't need to cut the muscle, there you are taking out the superior rectus and transposing it to laterally. But what happens in these procedures is it is just taking a loop of this thing and transferring here. So basically what is happening, this muscle, you're taking a part of it, 1/3 of it, and basically pulling it towards, you can say, about 10 millimeters from the limbus and anchoring it here. So the vector forces shift here. So that is how the eyes medially, the superior and inferior rectus can be transposed here without actually disinserting, and that will put the eye out. So that is something which is known as a modified Nishida procedure, where there is no risk of anterior segment ischemia because you're not disinserting the muscles and just transposing it. Now, how it helps you, basically, if you see here a left 6 nerve palsy, but the deviation is so large. So when the patient is looking towards the left side, you can see here the patient is looking left, the eye is just not moving out. So there is a very large deviation and the lateral rectus is just not functioning. Now, if you do just simple procedures like loosening this muscle or maybe transposing the superior rectus and to the lateral rectus, it really won't work because it's such a large deviation. So basically, because of this procedure, when you're not disinserting the muscle, we could easily do a 4 muscle surgery here. So basically what we did here was, we loosened this muscle, basically the medial rectus which is pulling it. We did a Nishida for the superior inferior rectus. So Nishida was again, this is what we did, here and here. So we loosened this muscle, we pulled this muscle here, the superior inferior rectus, and we plicated the lateral rectus. That means folded and tightened it on itself. So the problem is there is no risk of anterior segment ischemia. The problem is with these muscles is that if you disinsert them, there is anterior segment ischemia. So we could get, you can say, a straight eye. So basically, I'd like to conclude here by saying that OPD imaging in the form of AIOS2025 is a quick investigation to plan surgery. With binocularity, improvisation in surgical procedures are helping achieve it. Only one muscle surgery can achieve good cosmesis in third nerve palsy, which was really difficult. And neotransposition muscle procedures can be customized to the amount of deviation without the risk of anterior segment ischemia. Superior rectus transposition, which is widely used now, is very effective in providing some adduction. Thank you for your patient hearing.
Well, that was a wonderful talk, Dr. Jaspreet, and any questions or comments, we can take one. And so which form of OCT do you prefer? Which?
Just the cassia, what we have the anterior segment OCT in.
Yeah, because I think normal OCT will not, you need a swept OCT for that. Right. So